This is the endocrine gland histology tutorial presented by the SchrDbb with reference Atlas of Histology Function and Clinical Correlation by Dongmei Cui. So we are going to start here with the introduction of the endocrine system. So in the introduction of the endocrine system, we need to know that the system which is involved in the production of hormones that are going to trigger the target cells for changing in functioning and production of for modulation of function of the human body is mostly the endocrine system. Now, inside the endocrine system, you need to know that it is generally divided into three. So you have the primary structures, the primary gland, the secondary gland, and the tertiary glands. The primary glands are glands that produce trophin hormones, and those trophin hormones are hormones that are going to be used in order to stimulate secondary glands, and then secondary glands are going to produce hormones that are going to act now on the target cells, and then result with the change in the functions of the different cells of the body. Generally, you need to know that there are three types of hormones. There are steroid hormone, peptide hormones, and amine hormones. So now, the different glands that we have, you have the pituitary gland. We have the pituitary gland is divided into two. It's divided into the anterior pituitary gland called the adenohypophysis, and it's divided into posterior pituitary gland called the neurohypophysis. Okay. Now the next gland that we have in the endocrine system is the thyroid gland. Then the next is the parathyroid gland. Then the next is the adrenal gland, the pineal gland, and the endocrine pancreas and the islet of gland. So these glands are shown generally anatomically on this. So here you can see the hypothalamus and the pituitary gland, which are connected together. You have the pineal gland, which is just posterior and the posterior part of the midbrain. We have the thyroid with the parathyroid gland posterior. We have the adrenal gland superior to the kidney, and then we have the pancreas. Lastly, you're going to see the ovaries and the testes when you're going to visualize the male and the female reproductive system. So these are the different glands. Now, generally, we need to know that the pituitary gland is considered as a primary gland. Why? Because it produces trophic hormones. Example of the trophic hormone are adenocorticotrophic hormone that is going to stimulate the adrenal cortex for the release of different hormones there. And it's also going to produce thyroid stimulating hormones that stimulate the thyroid gland to produce a thyroxine hormones. Then to produce the thyroid hormone. Then it also produces the gonadotrophin that is going to stimulate the testes for spermatogenesis and also the production of testosterone, and it's going to stimulate the ovaries for the production of estrogen. Then you also have the luteinizing hormone that inhibits the production of estrogen and progesterone in the body, and also the luteinizing hormone is going to be suppressor of testosterone secretion, luteinizing hormone. Then we have the next hormone which is being secreted is luteinizing hormone is going to stimulate ovulation inside the females, and luteinizing hormone is also going to stimulate testosterone production inside the males. And this is follicle stimulating hormone. Follicle stimulating hormone inside the male promotes spermatogenesis, and inside the female it promotes estrogen production. Now this is the prolactin. So prolactin hormone now is going to help in the growth of mammary gland for the secretion of milk. Then you also have somatostatin. You also have growth hormone, which is going to help in the production of insulin-like growth factors in the liver, which helps in bone growth, in muscle growth, and adipose tissue growth. Then the next are the different hormones in the posterior pituitary glands. We have antidiuretic hormone, which is used in the absorption of water in the kidney. We have oxytocin, that is used in uterus contraction, that's used in the expulsion of the fetus at term, and also oxytocin is also used in the contraction of the mammary gland for expulsion of milk. So generally, that's why the pituitary gland is considered as a primary gland, because it produces trophic hormones. So that's why all the different hormones which are produced by the pituitary gland finish with the end with troph. Adenocorticotrophic hormone is also called corticotroph. This is also called thyroid troph. This is also called gonadotroph. This is also called somatotrophs. So pituitary gland, generally you have the adenohypophysis, that's the anterior pituitary gland, and you have the neurohypophysis, the posterior pituitary gland. The anterior pituitary gland is generally divided into three. We have the pars distalis, and the pars distalis is made up of the chromophores and the chromophores. The chromophores are made up of the acidophores and the basophores, and then the pars tuberalis is the next part of the adenohypophysis. Then we have pars intermedius, which is made up of the brachis and the basophil cells with melanotrophs. Now, the next one, we have the neurohypophysis. The neurohypophysis is made up of the neural stalk or the infundibular stalk. It's made up of the median eminence and it's made up of the pars nervosa. The pars nervosa consists of the herring body, the neurohypophyseal hormone, that's adenocorticotroph. It's made up of antidiuretic hormone, and the next hormone is oxytocin. So now let's start with the overview of the pituitary gland. So the pituitary gland is a small bean-shaped gland which is about 1 centimeter in diameter and located just beneath the hypothalamus and separated by the diaphragmatic cilia from the hypothalamus. So they are connected with the hypothalamus with the infundibular stalk, and they lie within the cellular tissues. Basically, so that's the characteristic of the pituitary gland. Just posteriorly we have the pineal gland. So the pituitary gland is above here. Now you have the optic chiasm is just anterior to the pituitary gland. That's why the clinical correlation is that when you have a pituitary tumor, you can have a compression of the optic chiasm, which can result to bitemporal myelopsia. That's why that is the patient is not going to see at the sides of his body, at the temporal sides. That is all bitemporal hemianopsia. So now this is a general histologic section of a pituitary gland. So general histologic section of pituitary gland, here is the hypothalamus far up here. Here we have the pars tuberalis, which is here. The pars tuberalis here, pars tuberalis, and there is the pars distalis. Separating the pars distalis and the pars nervosa of the posterior pituitary gland is the pars intermedius, and this is the pars nervosa here. So this is the schematic diagram now of the pituitary gland. The next thing is still on the pituitary gland. Now you need to know that generally what we use in order to visualize the pituitary gland is the myeloid stain. I also use the hematocyte stain. Now this myeloid stain is very important in order to name the cells of the pituitary gland, either chromophores or chromophils. Now, chromophores are the cells that are going to absorb the myeloid stain. Trichome is because it is made up of chromium salts. Is it clear? It is called myeloid trichome. That trichome comes from the derivative of the chromium salt. So chromium salt. So now the next thing I want to tell you is that when you hear the word phobes, when you are phobic, it means that you are afraid of, and when you are philic, it means that you like something. So when I say chromophobe cells are cells that are not going to absorb myeloid trichome stain, while the chromophil cells are the cells that are going to absorb the myeloid trichome stain. Is it clear? Now let's see, in the pituitary gland we use now this stain, myeloid trichome stain and hematocyte stain. So it's going to distinguish now the chromophores and the chromophil cells. The chromophore cells are not going to stain with this myeloid trichome, while the chromophil cells are going to stain either acidophilic or basophilic. Now acidophilic cells, which are chromophores, are going to stain reddish, while basophilic are going to stain bluish. So these are different cells here. So this is a capsule here. As you can see, this is the pars distalis, the pars intermedius, and the pars nervosa. So now let's visualize now the pars distalis. When you increase the magnification here, you can visualize that inside the pars distalis you have two main types of cells. You have the chromophore cells and you have the chromophil cells. Now the chromophore cells, as you can see, they are much more paler they are not staining, so they are very pale. They are not staining well with the Mallory trichome cells. Are you getting? Now, why the chromophile cells now are divided into two, you have the acidophils and the basophils. The basophils are going to stain bluish with chromium, so that is the Mallory trichome stain. Why the acidophils are going to stain reddish, as you can see here. Why the ones that stay paler are the chromophores. So when you stain pale, you are chromophore. When you stain, you have a color with the Mallory trichome stain. You are chromophile, and those chromophile can either be basophile that are going to stay bluish, or they can be acidophile that are going to stay reddish, as you can see here. Now you need to know that what the chromophile cells generally are going to secrete thyrotrophin, that is thyroid stimulating hormone. They're going to secrete follicle stimulating hormone, and they're going to secrete corticotropin. So generally those are, so acidophile granules are characterized to secrete somatotrophs 1 and prolactin. Are you getting? So when you have acidophilic granules generally they are going to secrete growth hormone and prolactin, that is somatotroph and mammotroph. Is it clear? Why the basophilic granules are generally characterized now to secrete thyroid stimulating hormone, follicle stimulating hormone. Is it clear? Now the corticotrophs, which secrete molecules of propionaminocorticotrophin, also have some basophilic granules, but you can also think of corticotrophs more of chromophores. So corticotrophs are more of chromophores, but they have only some basophilic staining. Is it clear? Why basophilic stain are generally when you are basophilic stain, generally you are secreting thyroid stimulating hormone and follicle stimulating hormone. When you are acidophile, when you are chromophile with basophilic granule, you secrete thyroid stimulating hormone and follicle stimulating hormone. When you have acidophilic granule, generally you secrete growth hormone and prolactin. And generally, when you are a chromophore, that's a clear staining, you are generally corticotrophs. So you secrete adrenocorticotrophin hormone. So generally, that is what is going to be the pars distalis. So this is just going to be the electron microscopic view of the pars distalis with the different granules here. This is the chromophile cells. So you see the chromophile cells with that can be possible somatotrophs. So chromophile cells, you have Golgi complex, the chromophore cells. The chromophore cells are still, you see, they are not staining well here. Is it clear? Those are the chromophore cells and the chromophile cells. So everything that has dark stain, that's in the chromophile cells, while the one that are pale are chromophore cells. Is it clear? Now the next thing is the pars intermedius. So the pars intermedius now contain what is called the racked pouch. So you need to know that in the embryonic origin of the pituitary gland, the anterior pituitary gland does not actually develop from the brain. It does not develop from the brain, but it comes from instead comes from a pouch from the nasal mucosa. Is it clear? So there is a pouch from the nasal mucosa which is called the racked pouch, and the remnant of the racked pouch is what is supposed to separate the anterior pituitary gland from posterior pituitary gland. That's why we have what is called the pars intermedius, and we have many racked cysts in between the pars intermedius, at the level of the pars intermedius. Is it clear? So we also have follicular cells which are surrounding those racked cysts, and then inside the racked cysts you have colloids. Is it clear? So that's what you have here. Now you have to know that the major cells which are located here are going to be basophilic cells, and those basophilic cells are producing melanocyte stimulating hormones. Is it clear? From the derivatives of propionaminocortin, they produce melanocytes stimulating hormone. They are generally basophils. Now the next one, this is the blood supply of the pituitary gland. Now we need to know that the pituitary gland is supplied by the superior hypophyseal artery and the inferior hypophyseal artery. Superior hypophyseal artery supply both the anterior pituitary gland and the posterior pituitary gland, but the inferior hypophyseal artery only supply the posterior pituitary gland. Is it clear? Now we need to know that the superior hypophyseal arch produces a first plexus of capillaries here, so the first capillary plexus here, and it come and produce a plexus of capillary here. In the posterior pituitary gland, the anterior and the inferior and superior pituitary gland are going, and inferior hypophyseal arch are going to anastomose and are going to produce their capillary system that's going to drain into the hypophyseal vein. But in the case of the anterior pituitary gland, only the superior hypophyseal arch is going to produce the first capillary system that is going to drain here the pars tuberalis. Then it's going to produce the next capillary system that is going to drain now the pars distalis. So what is going to connect the first capillary system and the second capillary system is going to be the portal vein, the hypophyseal portal vein. And you need to know that there are only two portal veins in the body: the hepatic portal vein and the hypophyseal portal vein. And the portal vein is defined as a vein that is connecting two venous systems. Is it clear? Normally, you don't have a vein connecting two capillary systems together or venous system together. So that's it. And you're going to have now the hypophyseal vein that's going to drain the next capillary system, secondary capillary plexus. So now here now is the pars nervosa. So pars nervosa is found now in the neurohypophysis of the posterior pituitary gland. So here we still use a trichome stain, but here it's not going to be Mallory trichome stain, but it's a Masson trichome stain. So with the Masson trichome stain, you realize that the cytoplasm of the this is going to is more clearer compared to the cytoplasms of the adenohypophysis. So in the neurohypophysis, that's the pars nervosa, it is much more clearer. And now when you stain with the Masson trichome, you are going to visualize different structure in the pars nervosa of the neurohypophysis. You visualize the pituitary site, you have the pituitary site, one, you visualize the herring bodies, and then you visualize the capillaries with the lumen of the small vessels. So what are herring bodies? So herring bodies are just the terminals of the axons of the paraventricular and supraoptic neurons. Is it clear? So the end terminals of these axons of the paraventricular and the supraoptic neurons are going to be called herring bodies. As you can see in this diagram, you have neurons that come from the hypothalamus. This neuron here, which is close to the ventricle, is going to be called the paraventricular neurons, while the neuron which is close to the optic chiasm, the supraoptic neurons. All these have their axon is going to have their terminals here, and those terminals are called the herring bodies. Is it clear? So when you increase the section, you see herring body is going to be purplish color, and then you see pituitary sites now with their nuclei here. Now this is the electron microscopic view. So you see the pituitary sites, you see finichated capillaries, you see axon terminal, and that finichated capillary, don't forget that it contains, they are lined by diaphragms. Is it clear? Now the clinical correlation of the pituitary gland now is a pituitary adenoma, and pituitary adenoma is a benign tumor of the anterior pituitary gland. Is it clear? So the benign tumor anterior pituitary gland, and the histologic section, what are you going to visualize? You're going to visualize pleomorphic nucleus of the cells. Is it clear? That is a prolactinoma with the hematoxylin and the resistant. But now when you use immunocytochemistry, you're going to visualize tumor cells which are going to be prolactin producing. So normally this is the normal prolactin producing cells, but here you see there are excess prolactin producing cells inside with the immunocytochemistry. Normally you see that they are not much on the normal section, they are reddish, but they are not much. But when you use the immunocytochemistry, you see that there is red all through with immunocytochemistry staining. So it shows that this is actually prolactinoma. Now in the pituitary adenoma, on the magnetic resonance imaging, you are going to see a radio opaque substance. So in case of magnetic resonance imaging, we say that it is having a hyper intensity. Now the next thing is the thyroid gland. So the thyroid gland, generally it consists of follicles, and separating the different part of the thyroid gland, you have the septums. Inside the follicles now we have the colloid. Now, in between the different follicles of the thyroid gland are cells. So we have the parafollicular cells, and those parafollicular cells are involved now with the secretion of calcitonin. So here are the follicular cells, which are cuboidal cells, and they are going to secrete tyrosine and the thyroglobulin inside the colloid, while the parafollicular cells are more of so the follicular cells can be cuboidal or squamous cell in origin, while the parafollicular cells are more of cuboidal cells, and they are clear cells or C cells, and are commonly located within the interstitial connective tissue within the septa. They are involved with the production of calcitonin, which is going to inhibit the osteoclast. So now Graves' disease now is the most common cause of hyperparathyroidism, and mostly occur in females with hyperparathyroidism. So Hashimoto thyroiditis now is another clinical correlation where you have a chronic autoimmune disease characterized by enlargement of the thyroid gland and the gradual failure of the thyroid function. So on the histologic section, what are you going to visualize? You're going to see so you're going to see reduced thyroid follicles. You're going to see the thyroid follicles number are going to reduce 1 in Hashimoto thyroiditis, and then you see lymphocyte with the germinal center, and then you're going to see hotel cell changes. So those are the different things that you're going to visualize. Now the parathyroid gland. So when you visualize the parathyroid gland, this is with a small magnification. So you're going to see also septa of the parathyroid gland, and the parathyroid gland is separated from the thyroid gland by its capsule. Is it clear? Now at the level of the parathyroid gland, when you increase the magnification with the hematocyte and using stain, you need to know that the parathyroid gland has two main types of cells. It's made up of the chief cells and it's made up of the ossifil cells. Is it clear? Those are the two main types of cells of the parathyroid gland. And then you need to know that each chief cell has a large round nucleus and a small amount of the clear cytoplasm. So these cells are involved with the production of parathormone. So chief cell or ossifil cells are the two main cells, and then the ossifil cells are large cells which have acidophilic, that's a pink cytoplasm. So they have acidophilic and pink cytoplasm, and each cell have a small nucleus and a large amount containing numerous mitochondria. So ossifil cells are arranged in cluster, or individual cells can be found scattered among the chief cells. Ossifil cells appear in the puberty number. Their function is unclear of the ossifil cells, and these are the chief cells which are more in clusters here. So the clinical correlation of the parathyroid gland is a parathyroid adenoma, and a parathyroid adenoma is a benign neoplasm of the parathyroid gland, which is going to represent most common cause of primary hyperparathyroidism, in which there is autonomous overproduction of parathyroid hormone. And then on the histology section, you're going to see adenoma composed of chief cells, and you have normal parathyroid gland with adipose tissue. So the next gland to visualize now is the suprarenal gland, and the suprarenal gland, generally on the gross morphology, you're going to visualize there's a capsule, there is a zona glomerulosa, which is the closer to the capsule, zona fasciculata, zona reticularis, and then there's a medulla in the center. So the zona, all these zonal layers are at the level of the cortex physically, and then you have the medulla inside. Now, so this is now the cortex. In this cortex, you have the zona glomerulosa, and the zona glomerulosa is made of the capsule, some capillaries, and different cells. Here you have zona fasciculata, general image. You have zona reticularis, general image here with capillaries, and then this is inside here is the medulla. So now this is going to be the electron microscopic view now of the cortex of the cortical cells. So adrenal cortical cell, generally this is how it's going to have. You are going to have lipid droplet. Lipid droplet is here because the cells are mainly going to secrete steroid hormone, and steroid hormone have a lipid content, so that's why you have mostly lipid droplet. You're going to have mitochondria. Now this endoplasmic reticulum, you have less of endoplasmic reticulum, but you're going to have more smooth endoplasmic reticulum. Why? Because the smooth endoplasmic reticulum is involved with the lipid formation. So more smooth endoplasmic reticulum and less of endoplasmic reticulum, because the reticulum of endoplasmic reticulum are involved with the production of proteins, and protein is not a steroid. Is it clear? So we have the nucleus here and the nucleus for the transcription and the translation to occur. The next thing now, we have pheochromocytoma is a clinical correlation here. It's a neoplasm of the adrenal mucous medulla characterized by the production of catecholamines such as epinephrine and epinephrine. So this patient is going to have the symptoms of fight and flight, so tachycardia, sweating, tachypnea and all that. So on the histologic section, what are you going to visualize? You're going to visualize adjacent normal adrenal cortex, but you have a pheochromocytoma with Zellballen. Is it clear? So Zellballen, these are the cells which are often arranged in nest and cell packets. So the cells are arranged in cell packet. This is called the pheochromocytoma with Zellballen. So when the cells are arranged in cell packet, it's called Zellballen. Now the next thing is the adrenal medulla. So they need to know that the adrenal medulla is the cells which are made up of in the adrenal medulla are mostly the chromaffin cells and the neuron cells, because on the embryologic origin of the adrenal medulla, it is much more going to contain neural crest cells. Is it clear? The neural crest cells are going to grow here, and then the neural crest cells are going to produce the chromaffin cell, and the chromaffin cells directly secrete epinephrine into the bloodstream, and no epinephrine, those are the catecholamines, directly into the bloodstream. Is it clear? So the next thing, so this diagram now are the cells inside the adrenal medulla. So example of the chromaffin cells, these are chromaffin cells here. This is the nucleus. Now you see that here you have more of norepinephrine granules. So the norepinephrine granules, you see they are not more as the lipid granules where it was very whitish. Here you have darkish granules here. Is it clear? And now another thing that you have to point again here, they are more rough endoplasmic reticulum here, because epinephrine and norepinephrine have some protein content. Is it clear? So the next gland to visualize now is the pineal gland, which is located at the posterior part here, the posterior to the midbrain. So this is the pineal gland. It consists of a capsule. There are septae inside the pineal gland, and there are brain cells inside the pineal gland. Is it clear? So the pineal gland is involved with the production of melatonin, which is used in controlling your sleep cycle. So for you to start sleeping, melatonin has to be released. Is it clear? Now the next thing to point out is the clinical presentation of pineal gland. Clinical presentation, you have calcifications. So calcifications occur at the level, so you have production of brain sands. So these are some brain sands. The more there is calcification, the more you are going to have brain sands within the pineal gland, increase with age. So the calcification appear white in computed tomography scanning. So that is it. Now you can see now on the increased magnification of this, you're going to see pinealocyte, and this pinealocyte is involved with the secretion of the melatonin, is it that control the circadian cycle. And then these are the brain sands, which are calcification here. Now the next thing to visualize here is a clinical correlation, which where you have a pineoblastoma, and a pineoblastoma is an aggressive malignant tumor in children which arises in the pineal gland. So on the histologic section, what are you going to visualize? You're going to visualize nucleus of the tumor cell, and you have synoptophysin in the tumor cells. So those are the different things you visualize. Then the last thing to visualize of the day is going to be the endocrine pancreas. So for an endocrine pancreas, you need to know that endocrine pancreas lies within the islet of Langerhans, and I've already said that islet of Langerhans are clear circular islets, as you can see inside the pancreas, while the other one is the exocrine pancreas. So inside the islet of Langerhans, it consists of different cells inside, but you cannot easily distinguish the cells by using the hematocyte stain. Here outside you can see exocrine secretory pancreas, which can be distinguished because the stain published by we just see that those several cells stain published, but here they cannot easily stain with the hematocyte as using stain. So a better stain to be used is going to be immunocytochemistry stain, which is going to stain preferentially insulin producing beta cells, which is going to stain them yellow. As you can see here, when you use this immunocytochemistry stain, it's going to stain the beta cells that produce insulin yellow, and the other exocrine cells are not going to be stained. So the clinical correlation here is the type 1 diabetes, which occurs because of no insulin is going to be produced since the birth of the child. Is it clear? So you have type 1 diabetes. Also, you can have also type 2 diabetes, where there's reduction of insulin produced due to increased insulin resistance. And now the next one here is the electron microscopic view of that. You can see this cell consists of the rough endoplasmic reticulum, Golgi complex, and all the like. So these are endocrine secretory cells. So the clinical correlation, another clinical correlation is type 2 diabetes. Type 2 diabetes is characterized by hyperglycemia with a normal or elevated insulin level, in contrast with type 1 diabetes, where there is low level of insulin or no level of insulin. So on the histology section, you are going to see exocrine pancreas, and then inside the islet of Langerhans, you see amyloid replacing the islet of Langerhans in case of type 2 diabetes. So from here you finish with the endocrine pancreas, and then we move on to the next chapters. So thanks for your kind attention, and don't forget to like and subscribe for the time. Thank you.